everybody. Hi, hi. Happy Friday. It's hard to introduce Dr. Carmen without a history and a reference to Herschel Tuman. So here we go. In the late 90s, Dr. Carmen wanted to work on reflux sympathetic dystrophy. He developed an infrared system to measure vascular activity in the hands. This backfired badly. In fact, Jeff said it was horrible, but it led to future things. It verified that infrared could be used to train vascular behavior. Rather than decreasing it, it increased it. So let's talk for just a moment about Herschel Tuman, who was the inventor of the NIR-HEG system back in 1994. This system was to increase blood flow, and it led to an enduring relationship between the two inventors who pushed each other to further development and research and to make a remarkable system that we now call PIR-HEG. This was invented by Jeff in 1998, prompted actually by a desire to reduce costs of the system that was being used by Dr. Tuman. Since then, Jeff has taught hundreds of professionals in virtually every country and continues to do individual teaching via Zoom. He was my personal teacher in this area. Very gentle, very smooth, answers every single question in the world there is about it. He's the designer and the developer behind the PIR-HEG headset and software. He's published in numerous peer-reviewed journals on the topic. He runs an ongoing listserv. He's been an ardent supporter of NRBS and just a darn nice person to know. I am lucky to introduce him, and today he's going to present on differential diagnosis traps, anxiety, depression, rage, hallucinations versus brain events of non-psychological origin. So thank you so much for being here, Dr. Carmen, and it's all yours.
Well, thank you. This is interesting. This is one of my favorite topics. And although I do have the option of advertising my PIR-HEG system, I'm not going to. This is strictly a diagnostic talk. And I find it really critical because many people that will come into your offices with various mental diagnoses will be diagnosed incorrectly. So I'd like you to think about, once this is over, whether the diagnoses of the people you're working with actually are correct. Oh, it's interesting, it doesn't matter. You all know this book, I know this book, it's a terrible book. The categories are really awful. They are mostly exchangeable one for another. But that's not actually the reason for this talk. The reason for this talk has to do with mental disorders that are not mental. So, when you're thinking about a diagnosis or working with somebody who comes in with a diagnosis, think about whether the behaviors that the person is exhibiting are kind of temporary, they come and go, or whether they're always there. That's a tip-off. Things that come and go quickly are very suspicious as brain events rather than as mental disorders. Here's some examples. It's an incomplete list, but all these things can be a brain event, and the brain event can last for up to several weeks, and they don't necessarily make up mental disorders. So as a traditionally trained psychologist, I learned about ways that the mind can create physical symptoms. And from that point on, practically everybody I saw had psychogenic symptoms where apparently physical disorders were really created by the mind. And that went a little too far. In descending order, these are the brain problems that will create mental disorders of a temporary nature. The most common ones you're going to see are migraines. They're very common anyway. They make up, 20% of the population, something like that. And a lot of the people you see are going to have migraines whether they have headaches or not. And migraines are famous for creating temporary mental disorders. Next in line is seizure activity, non-convulsive. And what that means is somewhere in the brain there's some discharging that doesn't belong there. And the discharging makes things malfunction or creates the appearance of something happening. So it can be either, but it's not real. The third thing would be convulsive seizures, which is a little weird, because there's a new category called PNES, which is psychological non-epileptic, psychogenic non-epileptic seizures. And these things, they're questionable. People fall on the floor and they thrash around, and they don't show any EEG activity. And then the final, well, not the final, but close to the final, inflammatory diseases like lupus, rheumatoid arthritis, MS, particularly lupus, will produce strange mental aberrations that generally are not permanent. They can be, but generally are not. They come and go. So if somebody comes in with a diagnosed rheumatic disease, you have to consider that the mental disturbances are not mental. And the least frequent thing you're going to see is a TIA, where there's a little stroke. But those are very often confused with migraines because they look the same. The differential diagnosis is that the person gets a headache and the symptom goes away, then it's probably a migraine. So most of the things that you're going to deal with will be migraine disorders, but not necessarily migraine headaches. So in your intake, if a person talks about headaches, you have to suspect migraine. And if you suspect migraine, you have to suspect that there are mental components to it that look like they're mental disorders. If you want to learn about migraines or any other headaches, the International Headache Society produces this international classification system 3. It's free. It's the definitive authoritative diagnostic system for headaches. It is accepted as authoritative by every single group that deals with headaches. It's worth joining the society, because then you get really, really good research on all kinds of headaches. So, migraines, the statistics vary all over the place. Among women, maybe 50% will experience a migraine. For men, it's lower. But you don't require a headache for the diagnosis. Sometimes with migraines you get a headache. Sometimes with migraines you don't. The ones that you don't can create temporary mental disorders that look like they're mental. And we're going to talk about that. We're going to talk mostly about migraine because that'll be by far the most common thing you're going to see. The mental things that you see are very similar with all of the other types of disorders that will create them, such as seizures and that kind of thing. It's tough. When you do an intake, I can't emphasize this enough, ask about headaches. And if they do say that they have headaches, find out when they occur. And this is really critical. The diagnosis of migraine has nothing to do with the presence of headache, and it has nothing to do with the intensity. But if somebody has a significant event, generally it'll be a headache. But if it occurs on the release of stress, not under stress, but when stress is shut down, that's a migraine unless you can prove otherwise. Let me repeat that. If you get a headache when stress shuts down, it's a migraine unless you can prove otherwise. It doesn't matter how much it hurts. The common times to get a migraine are the end of a bad work day or the end of a bad day at school, or Friday when the work week shuts down, or even the first day of vacation. Those are migraines unless you can prove otherwise. Now, migraines come with sort of 4 stages: prodrome, aura, headache, and postdrome. Not everybody experiences a prodrome, but a lot of people do, and they can be subtle. It's kind of a buildup of irritability. The typical person will build over 2 or 3 weeks, and at the point of peak buildup, they will end up with a migraine headache that day. With school kids, you often see learning disabilities that become progressively worse. Then the kid will get a headache and they don't have the learning disabilities for a while. You can see it with expressive and receptive speech. So the prodrome is a long stretch of increased irritability. The aura is generally considered more interesting. The migraine mechanism starts somewhere in the back of the head usually, and it moves forward 2 to 6 millimeters a minute, and at some point it stops. And that's called cortical spreading depression. And when it stops, that's generally when the headache occurs. Now, the problem with the diagnosis is that very often the aura is silent. And when the aura is silent, people think they don't have an aura. But you get really intriguing things like emotional things that look like an emotional reaction that comes from mental things, when actually it's the aura. It just depends on what part of the brain the migraine mechanism is hanging out at the moment. It can produce rage reactions, panic reactions, distortions of size. It can produce almost anything the brain does for a living. So you have a maximum, generally 60 minutes of duration for the aura. And any person that comes in that has behaviors that run less than 60 minutes, you have to consider migraine even if they're not complaining about a headache. just covered this, but the emphasis here is that the headache is optional. So if somebody comes in with rage reactions that they're trying to get control over, or panic reactions particularly, if they don't have a trigger, and you can't identify one, think about migraine. Seeing ghosts is one of my favorites. People complain of seeing ghosts, and they look like ghosts. It's actually scintillating scotoma. It occurs during the aura, and there's these white floaty things running through your visual field. So I developed a long time ago a diagnostic test for it, and I have people close their eyes. If the ghosts remain with the eyes closed, they're okay, it's a migraine aura. If the ghosts go away, then the person has to decide if they're friendly or not and how to deal with it. But generally, people say when they close their eyes, they still see them. And that's because the visual image is being generated in the occipital area. The same goes for hearing voices. Auditory hallucinations. Now, almost all the psychiatrists I talk to, when they hear about somebody hearing voices, they think psychosis. But, might not be. Auditory hallucinations that are followed by a headache are a migraine aura. They are not psychosis. More interesting than that is losing the ability to understand speech. So this person will be having a conversation, and the person they're talking to sounds like they've just slipped into a foreign language. And they have no idea what they're saying. And then all of a sudden they resume English, if that's the native language, and then the person gets a headache. So you've got the nice sequence of the migraine working its way forward through the head and triggering an event like this, and then the person gets a headache. So that's not a mental disorder, it's a migraine. ADHD, that may not make a lot of sense, but particularly with the prodrome, as irritability increases and frontal lobe function decreases, these kids will get more and more hyperactive and more distractible, and then they'll get a headache and they'll be okay for a day or two or a week. So when you're doing diagnostic testing, be careful of when you do the testing and make sure you're not measuring things like migraine activity. Depression might seem like a surprise, but if it goes away after a headache, it's a migraine. Anything that goes away after a headache is probably migraine. However, lupus, which is also one of these things that generates weird mental behaviors, will typically produce depression and a headache about a week before the lupus flare occurs. So people will get sick about a week later, but it will be preceded by depression and a headache. And the headache doesn't respond to PIR-HEG, and most migraines do. And the depression has no mental source. They can't say why they're depressed, they just wake up depressed. And about a week later, they're really sick. And the advantage of that is that they're able to adjust medication, bump it up a little bit, and maybe hold off the severity of the flare. But if you get depression and a headache a week before a person gets sick, you need to think about lupus. Okay, social anxiety disorder, another thing we treat people for. If it's followed by a headache, consider migraine. Consider the pattern. The headache normally, as I mentioned before, with a migraine will come at the end of a bad day. The sense of anxiety will tend to precede that. So they may feel uneasy, not know where it came from. And then the day is over and on the way home they get a headache. That's always migraine. Same for generalized anxiety disorder. Same for focal phobias. You get a headache afterwards, it's migraine unless you can prove otherwise. Panic, generally people can describe a reason for the panic. And if they can't, and if it's followed by a headache, it's a migraine. This is an interesting one. The International Headache Society now considers cyclic vomiting syndrome to be clearly a migraine. They typically occur with kids, and these kids will just throw up spontaneously. When the kids hit adolescence, it tends to morph into headaches. But it's not, it has nothing to do with the gut. It has nothing to do with needing to vomit and all that. It's basically a migraine, and it's clearly considered migraine now. And they do respond to the PIRHEG as if it's a migraine headache. That's somewhat diagnostic. You probably have seen seizures, whether you realize you have seen seizures or not. This list at the bottom, it covers some of them. The absence seizures are just a shutdown, usually a matter of a second or two or three, where everything freezes, and generally the person won't know anything happened. Those are kind of obvious. The partial seizures are less obvious. Can you see my cursor here? No? Yes, good, okay.
Yes.
So,
yes.
Partial seizures are very much like migraines. They represent something, and the something they represent can vary all over the place. It depends on where they're located. They're a part of the brain that's discharging, and it can be almost any part of the brain. And what that brain does for a living, those things will either malfunction or create symptoms that weren't there. It's hard to tell the difference between partial seizures and migraines, except you don't get a headache when it's over. And it isn't necessarily easy to pick up on an EEG, even a clinical EEG in a laboratory may not pick it up. The tonic-clonic ones, the convulsive seizures, are easy to tell that something happened, but they actually can be mental. The PNES, the psychogenic non-epileptic seizures, it's a big deal now, and there's whole clinics devoted to it. Personally, I think it is heavily overdiagnosed. A lot of people won't send the seizure signal through the skull. So even with a really well-done clinical EEG, you may miss it. I have my own diagnostic criteria for this. So if a person has a seizure and falls on the floor, and on the way down, their head hits the corner of a table, it's a real seizure. Whether there's EEG evidence or not, it's definitely a real seizure. The PNES folks don't hit the corner of a table. They fall down and they miss the table, and they miss the chair, and they don't hurt themselves. So there are people where it's definitely psychogenic, but I don't think there's a lot of it. Most of it's real and just unable to detect the EEG. When people have drilled holes in the skull and inserted depth electrodes when surgery is being planned, generally these invisible seizure discharges show up. So I think it's mostly an inability to detect something that's there. The inflammatory diseases are really important. Lupus I mention a lot because that's the worst of them, and because I think lupus is heavily underdiagnosed. Probably 20, 25 years ago, the American Rheumatology Association tightened up the criteria for diagnosis, and at that point, the diagnosis of chronic fatigue syndrome increased, and fibromyalgia increased, and lupus decreased. But the length of time it takes for blood work to come back on lupus is usually about 20 years. So a lot of people have lupus and don't know it. It tends to affect the brain most of the time. Now, the rest of the body organs are what people worry about. It affects the kidneys and things like that, but it affects the brain. And you'll see it as this 1 week lead time of depression and a headache. But it can do other things. It can create psychosis. It can create temporary strange things, like I've had patients where they're in the kitchen and they take a utensil and bring it over to the table, and then they repeat the action several times and don't have any idea that they're doing it. And these are lupus folk. It's a nasty disease. Be on the lookout for it. The other rheumatology diseases are similar. They're all kind of cousins, but lupus will do the most weird kind of things for mental disorders. TIAs, you will not see many of these, but some people have them. Basically, there's an interference with blood flow in the brain. But very, very often they are actually migraines. The likelihood of somebody having a TIA in your office is pretty slim. They may come as a referral if the TIA presented as a mental disorder, which it could have. But you're not going to see that many of these. So, think about anybody that comes in with a diagnosis of a mental disorder as maybe it's not. And if the things that are mental come and go with a relatively short duration, maybe 60 minutes or less, think about migraine. And I'm ready to take questions. This went faster than I expected it would today. I'm open to questions.
Okay. Okie doke. Good. Got a couple of questions. Thank you so much. It's always a good refresher for me. And then there's always something new that I probably heard before, but I don't remember having heard it. So thanks again. Question from Mitch Sadar. You are expanding migraine to include non-headache events.
You bet.
Okay, so you know how this question is going to go. Wouldn't it be better to say that such non-headache events suggest a paroxysmal event occurring somewhere in the brain?
That would be a refinement, but migraine absolutely positively does not require a headache. Take a look at the International Classification System. It defines it really very carefully, but migraine as an event does not require a headache.
Right, but all of these other events that may be occurring without a headache are also not necessarily migraines. They are paroxysmal events. So it seems that you can look at the world as just about everything's a migraine, but I don't think that it's a good generalization. I mean, I think it's a better generalization, to say that much of what we see probably involves some paroxysmal event in the brain that may not be being picked up by the typical assessment measures.
I would buy that. I think you should consider migraine as a high probability because it's such a high probability event.
Okay.
20 to 50% of women will have migraines even if they're not sure they're having them. And if somebody has migraine and if somebody has a paroxysmal event, you should at least consider the linkage between the two. But I do agree that you can have all kinds of paroxysmal events that are not migraine. It's just that they're going to be the most common.
Thanks.
Great question.
Okay. Here, not sure if it's Dr. Baruch, so I'm going to say that. Nurit Baruch, I hope I got it close to right. It brings up the idea of diet, nutrition. I had terrible headaches with vomiting, and after DNA testing, eliminated garlic and gluten and got my life back. That, for me, kind of raises the question of, can you talk a little bit more about gastric migraines and how that ties in with everything that you've been talking about?
Yes, sort of. The migraines that occur in the digestive tract, the cyclic vomiting syndrome, and things like that, they appear to be regular migraines, just representing in a different location. They don't particularly connect with diet, except that things like gluten with some people have had a major impact on the migraines in general. I was a holdout on that for a long time, but I had people spontaneously telling me that their migraines got a lot better when they eliminated gluten. And it turns out for some people, it's definitely a variable, but it doesn't have very much to do with abdominal migraines as such. It connects up just as much with head pain. Does that make a sense?
Mm-hmm, mm-hmm. Yeah, tricky business, I find.
Yeah, it's interesting though.
Yeah, yes. Francis Bauman says, you had listed conversion disorder on one of your slides. Can you expand on that in the context of the discussion? Physiological events that can mimic physiologic conditions. Does this mean that symptoms are always time limited? I'm not sure how to read that question. If it's like a series of 3 separate questions,
Yeah.
you can sort through that. I guess let's have you expand on the conversion disorder if you can.
I've seen a bunch of them over the years. I don't understand them. They are usually they seem mental. Sometimes it's questionable. I've had 3, I think, with conversion blindness, and they definitely could see. The perception of vision was shut down. And one we fixed by having her sister walk her along a highway with cars zooming back and forth, and it became dangerous, perceptually dangerous. It wasn't really dangerous, but that busted through it. But conversion disorders fall into the category of things that sometimes really are not conversion, they're really real, but they're diagnosed as conversion. So I don't really know how to deal with conversion disorders all the time. And there was more to that question, but I'm not sure I remember it.
Yeah, so are symptoms, does this mean that symptoms are always time limited?
Symptoms that are time limited, you have to suspect a brain event like migraine. Conversion could be constant. But time-limited symptoms, especially if they end with a headache, that's a migraine until you can prove otherwise. They don't have to end with a headache. But a migraine aura generally will not last more than 60 minutes. Sometimes they do, but generally, any event that shuts down after an hour or even 30 minutes, you should at least suspect migraine rather than a mental disorder or some other kind of disorder.
So when someone says, I've had a migraine for 3 days, where does your thinking go?
That's different. The headache, once it kicks in, can last. But the aura generally will shut down within 60 minutes. And most people have an aura and they don't know it. The research with migraines is actually divided for medication. It's divided between those that have auras and those that don't. But it's a really artificial distinction because they're looking at mostly at scintillating scotoma, visual things that are floating and things that are easy to identify. But they're not looking at a change in mood or things that are subtle enough that you won't link it to the headache. I think most people have an aura.
The more you talk, the more the questions are like flying in. So can you elaborate on aura without migraine?
Yeah, oh sure. They're complicated because it's harder to figure out what you got. My diagnostic procedure often is try them on the PIR-HEG because the hit rate is so good with migraine that if it disappears, it's kind of likely it was a migraine. But that's a sloppy kind of diagnostic. The 60 minutes is a decent measure. Auras run 30 to 60 minutes maximum. Sometimes longer, but generally that's a decent time span. The symptom itself may only be a few minutes, but if it's a short duration of an hour or less, and the person doesn't know where it came from, all of a sudden they're flying, yelling at their family members, or all of a sudden they're in a panic, if they can't identify a genuine, significant trigger, at least suspect migraine.
And what is your understanding of the pathophysiological root of the migraines? And I'm going to add to that, do you have any opinions about how that relates to EEG readings?
That's a wonderful question, because when I developed the PIR-HEG system, the pathophysiology was clearly vascular. And both Herschel and I were working on control over the vascular system in the brain and that kind of thing. It tangentially has a little bit to do with the cerebrovascular system, but it's certainly not a cause, and it doesn't have a whole lot to do with it. It doesn't even have a whole lot to do with the pain. It's a complicated mix of the trigeminal nerve and the brainstem and general irritability and things like that that eventually trigger. With EEG, what you should see, and I don't know that it's that clear, but you should see an increase in what looks like irritability, and then after the headache, you should see some normalization. But I don't think the EEG markers are very clear.
Mm-hmm. So the irritability could be like high beta, excess fast waves. Yeah.
It could be. I mean, it can be so many things. You might even get some discharging stuff going on during the high irritability. I think that the key is timing it. If the EEG changes after the headache and it looks more normal, then you have a suspicion that you've got an EEG marker.
Mm-hmm. Mm-hmm.
That's a tough question.
Yeah, yeah. Okay, yeah, and I don't like so much doing EEGs on people with migraines anyway. So I like to be real gentle with them. Let's see. I'm going to combine two questions again. Other than PIR-HEG, what are some accepted behavioral treatments for migraines? And can you talk a little bit about what's involved in learning PIR-HEG?
Sure, those are really two separate questions.
Well, it's kind of it.
The historically tried and true solid biofeedback way to treat migraines is with finger warming. I don't know why. It tackles the wrong things. It was based on the vascular theory of migraines, which was incorrect. It has something to do with generating brain control over physiological systems, and it probably has to do with what it takes to increase the signal on PIR-HEG. In order to get a signal boost out of PIR-HEG, you need to have a relaxed focus. If you focus really intensely and you're not relaxed, the signal will not increase, it'll decrease. And if you relax without focusing, it'll decrease. So it needs both at the same time. And generally, people who are successful with hand warming, finger warming, that's generally what they adopt. The difference is, and I used to do a ton of that, peripheral hand warming, it's slower. It takes a lot longer to have an effect than with the PIR-HEG stuff, but it does work. A lot of people work with migraines will send the people home with temperature trainers, and I don't bother anymore. It just doesn't seem necessary, but it does have an honorable historical history. I just don't think it has much to do with what the blood vessels in the fingers are doing.
Can I jump in here? We've got Saul Rosenthal in the audience, who I view as a guy that knows a lot about these types of things. Saul, what are your thoughts about other forms of biofeedback for migraine?
Gosh. Well, I mean, I certainly agree with Jeff. I mean, historically, I mean, hand warming was one of the first biofeedback methods to use, period, and it was for migraine. It seems to work, probably not, as Jeff said, for the reasons why. I think heart rate variability has been shown to be helpful with migraine as well. And I believe there's been some neurofeedback work, slow cortical work, I think, has been useful. But I know I always go for the PIR-HEG first at this point.
It surprises me still how effective it is. I think the mechanism for all of the treatments has to do with allowing the prefrontal cortex to become dominant, or at least reducing the dominance of the limbic system. But when the negative feedback loops are tightened up, migraines don't go away. What actually happens is that they are just as frequent, but they're less competent. So people have a harder time telling they had one, but they get them just as often.
How does that get measured?
With pain.
But if they're not having the headache?
It takes some effort on the part of working with a person to identify them, but like people who will get a migraine at the end of a Friday night after a week of work that's been stressful, they'll feel something. They'll notice that something has happened, and they might get a little headache, but most folks will distinguish between mild headaches and severe as not migraine and migraine, but it's all migraine. So a mild headache in the same situation that they previously would have gotten a severe one is still a migraine. It's just not very high quality. The reason I use high quality as a term is that I've come to believe that the purpose of migraines going back 50,000 years or so is to warn the rest of your tribe that there's a storm coming. Because a large percentage of migraineurs will be storm sensitive, and what they're picking up is a rapid decrease in barometric pressure. And that tends to trigger migraines, and that would have been a wonderful asset to have with a group of people who needed to seek shelter if there's a big storm coming in. So I think we're making people generate less competent migraines, but they don't actually need to function anymore.
Thanks, Jeff. Dr. Fink might need to help me elaborate on this question, but looking to define mental versus physiological disorder, and how is a migraine measured?
Lots of different ways. There are standardized checklists that I don't particularly like, but people can assess a pain level they're tough because as you start improving the control over the migraines and they hurt less, people who are ranking it, for example, on a 0 to 10 scale, they tend to increase lower levels. So if the headaches used to be maybe 8 or 9 on a 0 to 10 scale, they'll start moving up 4 and 5 up to 7 or 8, and you have to then move the criteria to how is it interfering with what you're trying to accomplish at that moment. Are you able to still read a book? Are you able to write what you've been writing? Are you able to do mathematics? So you have to start measuring it in terms of the degree of interference, which is not necessarily the same as the perceived pain level. Does that make sense?
Yeah, but it's pretty complicated.
It's messy.
Yeah.
It's really messy.
The other question I had, which is kind of wading into pretty tricky philosophical issues, is how do you define mental versus the physiological?
Mental is however I define it. How's that?
He's the boss.
Mental, I mean, it's all physiological, but mental is stuff that, in my definition, would not necessarily have a direct, definable physiological correlate. So, emotional stuff tends to float around the right temporal lobe, for example. But if it's really mental, you're not likely to see an EEG correlate of it. They're not likely to get a headache when it's over. The migraine auras in particular, they're short-lived. And most mental things, meaning emotional without necessarily a physiological driver, they have an emotional stimulus, internal or external. And if they come out of nowhere, that approaches my category of physiological. So it's a great question without a great answer.
Yeah, you're in the middle of some tricky philosophical issues.
Yeah.
Mind-body stuff, and yeah.
I don't know the answer. It's just...
Yeah, nobody does.
And let's see, this may be our last question. When dealing with young kids with learning problems, whether they have aggression or not, how might you assess for a migraine event?
Oh, that's a wonderful question. Kids are so often misdiagnosed. Think of, if you identify either a cyclic vomiting problem or a periodic headache problem, you should suspect that these changes are brain changes rather than constant state things. Somebody with a definable learning disability should have kind of the same thing most days. You know, if it's more oriented towards math, it shouldn't be better on Friday than it was on Monday. But with migraine stuff, it changes. That's the main differential, is that if somebody is pretty bad over a time span, either with a prodrome or an aura, and then they have a headache and they get better, that's really a migraine effect, unless you can prove otherwise. Let me throw out one more variable. this I have been more and more aware of over the years. Excuse me. The effect of mental fatigue. The prefrontal cortex, which is responsible for at least being in charge of what you're focusing on, it fatigues very quickly. Sustained mental effort, which is a term coined by Carl Pribram years ago, it fatigues very quickly. People with a head injury, kids and adults, will fatigue within 4 or 5 minutes. Normal is around 10 and peak performers are around 20. So one of the variables you can watch for is how fast people are fatiguing, including kids. And this is a serious issue in terms of doing diagnostic testing with them. Take somebody who fatigues after 5 minutes and do a neuropsych battery with them. You're measuring a lot of fatigue. So much of the pattern of response will depend on whether they're tired or not. So that's just a separate variable.
You certainly gave me things to think about in terms of my clients, and I got to go back to the drawing board on a few of them. Thank you. I appreciate everybody joining us today. The recording will be available before long, a week or two. You'll get a notification. Join us for the next CE series. You have any questions?
Shoot me an email.
There you go. Okay. And if you don't have, I'm not going to put it in the chat because we're going to wrap up, but you can reach out to NRBS. So send any questions our way and we'll get you taken care of. Good to see everybody. Thanks, Dr. Carmen. Great to see you.
Thanks for the opportunity.
Thank you.
Take
Bye-bye.
care.